A very good morning, everybody. I will be talking about the tissue response to surgery. Once we know that the medical therapy has failed and we have resorted to the surgical treatment for the patient, it is very important that this surgical treatment works for the patient. So the predictors of filtering surgery are the appropriate surgical technique, which would be elaborated upon in the forthcoming presentations, and the development of the filtering bleb, which is influenced by wound healing and subconjunctival scarring. Trabeculectomy is nothing but a series of incisions, and it's actually ironical that we want most of our incisions not to heal completely except for the conjunctival incision. So it's a kind of a balance which we have to strike, and we have to take care of this tissue response while we are following up the patient post-operatively. For trabeculectomy, there is a functional endpoint and a structural endpoint, as is there with the most other surgeries. So we want that there should be a good outflow facility which has been surgically induced, and the bleb morphology is favorable so that the bleb functions for long. There should be minimal inflammatory response, and the histology of the bleb capsule should be favorable for the function to be established for a long period of time. So why do we need to know about wound healing? From a structural point of view, if we have the knowledge of tissue response to this surgery, it would help us to better interpret correctly the morphological appearance of the developing filtering bleb. Plus, the bleb appearance may also help us to predict the outcome and take preventive measures if the bleb is about to go into failure. And it will provide us clues whether we need to add another, say, anti-metabolite injection in between, or whether we need to revise the bleb. So unless we know the wound healing cascade, it wouldn't be really helpful to follow up the patients. It's actually a scar ward. So from a functional point of view, if we see post-operative wound contraction and scar formation, they increase the resistance to aqueous outflow, which will eventually lead to elevation of intraocular pressure, and that is consequent to reduction in the bleb surface area, which is available for the aqueous absorption. So if we look at the bleb, which is there in the picture, there is very minimal area which is there for the absorption of the aqueous. Plus, there is reduction in the porosity of the bleb wall as determined by the thickness of the bleb wall. So if there is a Tenon's capsule, Tenon's cyst which is forming, the wall of that being thick, there would be a reduced porosity of this wall, and there are more chances of the scar tissue getting formed. Plus, there is a reduction in the volumetric absorptive capacity of the surrounding tissue. So the fluid cannot spread around and cannot be absorbed. So there are two basic concepts to healing in trabeculectomy. One is replacement, where we are trying to have restoration of near normal epithelial and stromal architecture. So if we are using mitomycin C or 5-fluorosil, the kind of bleb which we eventually get is because of the replacement bit of the tissue response. On the contrary, with regeneration, we are actually getting more like, we are actually getting the original architecture, and there is no trace of any surgical injury. So if we use a collagen matrix like an ologen implant, or if we are using an anti-VEGF agent, we are getting a near physiological kind of an architecture. So regeneration is sticking to that concept. There are three important factors which make the aqueous drainage pathway different after the filtration surgery. First of all, there is a bypassing of the trabecular meshwork and loss of phagocytic function. The subconjunctival tissue plays a quintessential role in the functional and the structural outcome, because it's an immunoactive tissue which is abundant in lymphatics and can throw a very bad inflammatory reaction and lead to scarring. And the nature and the type of aqueous, because of the changes in the blood-aqueous barrier, can also influence the ocular immune privilege system. So this is what happens after we do a filtering surgery. There is a release of plasma proteins in blood cells, which leads to formation of a fibronectin clot. There is replication of cells and immigration of macrophages, fibroblasts in the area, and formation of new capillaries. Then there is a degradation of this clot, and fibroblast synthesis of collagen, glycosaminoglycans, and fibronectin occurs. which will ultimately lead to formation of the fibrovascular granulation tissue. And this process continues on, and there is continued collagen synthesis, reabsorption of the cells, and disappearance of the fibroblasts. Depending upon how much fibroblasts are there after a certain phase of the surgery, we would be able to know the functional outcome of our bleb. And if fibroblast activity continues, we get a dense collagenous subconjunctival scar. So we can intervene at various steps of this cascade to make our surgery work. Essentially, when to intervene would be more appropriate. We can know it better if we know the three phases of the wound healing in the trabeculectomy. The first one is the inflammatory phase within the first 7 days, where there is a lot of inflammation and cell migration. Lots of cells are induced in the surgical area. If we see the picture where we're showing a picture of post-operative day 7, there is so much of capillary, neocapillary growth in that, and it is a highly vascularized red. So if we intervene at this time, we would be able to salvage the fibrosis which can occur because of this kind of a capillary growth. Then we have the proliferative phase, where capillaries and epithelium are setting in, and that is followed by remodeling and cross-linking phase, which can go on to years. So early acute inflammatory phase has significantly increased transcript expression of various factors, most importantly the VEGF. There are more mitotic cells and subconjunctival fibroblasts. This is a bleb of close to 1 week or 1 month post-operatively, and we can see that it is getting capsulated, and at the border of the bleb we are getting a kinking of vessels. So that is showing that subconjunctival fibrosis is happening underneath that area. In the late fibrotic phase, there is an increased expression of TGF-beta2 and extracellular matrix genes, along with notable reduction of the infiltrating inflammatory cells. Mitotic cells and subconjunctival fibroblasts persist in this stage. This bleb is a year post-operative bleb, and because of the continued fibroblastic activity, this bleb has almost lost its height. It's pretty flat, and that's how functionally it looks like. There is an immense influence of long-term topical therapy on the outcome of the surgery, and that is because the tissue is primed that way. There is cellular response which may result in high post-operative intraocular pressures. The fibroblast phenotype is majorly altered because of the preservatives in the drugs, and that leads to activation of fibrotic response. Mitomycin C and 5-fluorouracil can halt this cellular growth, but these growth-arrested cells are able to stimulate neighboring cells to scar via the growth factors. Similarly, conjunctival inflammation can also influence in a negative way the post-operative outcome, because the epithelial cells continue to express surface antigens even after surgery. We can get a ring of steel formation, usually seen in anti-metabolite augmented filtering surgeries, because the fibroblasts at the bleb edge may have increased activity as a result of the central bleb area having treatment with the anti-metabolite. Very little is known about the physiological signals which initiate the end of the wound healing, but it is definitely a known fact that fibroblast apoptosis is very, very important. Mitomycin C and 5-fluorouracil, they do not inhibit fibroblast proliferation, but they do cause a long-term growth arrest, and they also induce apoptosis. So application of the concepts which I just mentioned is that pharmacological intervention that modulate the wound healing pathway can be described by the mechanism of action and by the phase of wound healing response of a particular agent. So if we classify that way, we have 4 main phases: coagulative, inflammatory, proliferative, and post-proliferative remodeling. So steroids would interrupt the inflammatory phase, whereas adjuncts like 5-fluorouracil would affect the proliferative phase of the surgery. So this is just a timeline, what agent to use at which proliferative step. So corticosteroids and anti-TGF-beta would work when we are in the acute proliferative phase and fibroblast activity has just set in. They and 5-fluorouracil and mitomycin C augmentation, either as injections or in the form of needling, would work once procollagen formation has already started. So the take-home message would be that the knowledge of this tissue response and the mechanisms of wound healing may augment blood survival, and for that we need to have a close blood surveillance. We need to look at the blood both functionally and structurally, and we need to intervene when we feel that the blood is just about to fail. Multimodal therapy with long-term plans for suppression of fibroblastic activity would help at the right time. Thank you very much for your attention.